National Limousine Health Program. And we will talk a bit about that program later on in this presentation today. But really, what we're going to do is we're going to take a deeper dive into what's going on in the health insurance market in general, and also what's driving the incredible cost increases that we've been seeing, and what are all your alternatives as a small to mid-sized business. What are all the options that you have? And yes, the NLA very proactively about 4 or 5 years ago decided to roll out an association health program that's working very, very well for the members that are participating, but it's not a fit for everybody. So we want to talk about all the options that are available to you today as we jump in. So um, we're going to get started. If I can get the technology working. Why is that not moving? Huh. Okay, folks. Oh, well, we're going to have to. Oh, there we go. So yeah, as you can see, we are going to talk about the state of health insurance in general right now, the state of the industry, what's happening with the various health insurance carriers, the pharmacy benefit managers, what is driving everything that's going on, and what might we see as we go forward here over the course of the next couple of years with the current administration and then beyond that. We'll talk to you about all the options that are available to you as a small and mid-sized business owner. And then we'll do a deeper dive into the NLA Health Benefit Program and the enrollment and management process, if indeed that's the proper fit for you. Let's kind of first talk about what's happening right now. And anybody that is purchasing health insurance, be it in the individual market or the small group market or even the large group market, you have seen some dramatic cost increases over the last couple of years. And they're being driven by a number of different forces. So as we look at this chart on the left, this kind of shows you back in 2014 where the reimbursements to hospitals for Medicaid and Medicare were only slightly lower than the reimbursements that were being paid by the private insurance market. And what you've seen now as we've gone from 2014 to present, we've seen that gap widen significantly. And the anticipation is that gap will continue to further widen, especially as we see with the current administration and the recent bill that was passed. We're seeing lower, reduced reimbursements to Medicaid. We'll probably see some changes with Medicare as we move forward. And all that is doing is putting greater pressure on the providers, the hospitals, the physicians, the practices to get more from the insurance carriers, the BUCAs, and we'll refer to them as the BUCAs a couple times throughout this presentation. The BUCAs stand for Blue Cross Blue Shield, United Healthcare, Cigna, and Aetna. Those are the four major players in the health insurance industry. Yes, there are regional players in certain areas of the country that do a very good job, and number of members are very happy with those. Kaiser is one of them. CDPHP up in upstate New York and Pennsylvania and places like that. So there are the regionals, but the BUCAs are the drivers, and that's basically what everybody's looking at. So there is continued pressure on the major insurance carriers from the providers to increase their reimbursement levels as they're getting less and less dollars from Medicare and Medicaid. And where do they get those dollars from? They get them from you, the members. So as we see the upward pressure on the carriers, we'll continue to see upward pressure on the premiums that are being paid. And then another phenomena that we're seeing, and that's the chart on the right, and you see the gap between hospital spending and total health spending is also widening. And that's happening for a couple reasons, but the biggest driver there is the cost of prescription medication. So back 15, 20 years ago, I'd look at a large company's health plan where we had all the claims data and everything, and we would see that the prescription drug costs were taking up 12, 15, maybe at the far side, 18% of the total health spend. Well, we're looking at accounts now where the total RX spend is in excess of 30% of the healthcare spend. And that's being driven by a lot of these biologics. We're seeing great advances in medication being created and being distributed and being made available as people need them. The Wegovy's and the Ozempics and all these other drugs, but those are very, very expensive drugs. And for a lot of them, there are no generic equivalents. And so we're seeing a much bigger percentage of our total healthcare spend coming from prescription drugs. And there is no reason to believe that that's going to change. And so we're going to continue to see the upward pressure on costs that we've been seeing. There's no expectation that that will be reduced anytime soon. Another thing that we're seeing too is renegotiations are driving costs. Back pre-COVID, the hospitals, for the most part, were negotiating with carriers and setting up reimbursement arrangements, and they would have 5-year contracts. And it wasn't unusual, and they would look at what medical inflation trend was, and they'd adjust the contracts accordingly. Well, then COVID came along, and a lot of these hospitals were locked into these contracts with the providers. And over the period that COVID was playing out, the hospitals were starting to lose money. And so now what we're starting to see is we're starting to see shorter timeframes for these negotiations. So instead of entering into 5 and 7-year deals, hospital systems are entering into 1, 2, and 3-year deals with the carriers. And that's creating a lot of uncertainty and a lot of anxiety in the market. Hey, recently we had a situation where Memorial Sloan Kettering, the #1 cancer hospital in the country, sent out a notification to all their members that were covered under Blue Cross Blue Shield, saying that the negotiations with Blue Cross Blue Shield for reimbursement were not going well, and that if they were not able to reach an agreement in the next number of months, that those members, their insurance would no longer be accepted at Memorial Sloan Kettering. Blue Cross Blue Shield, of course, was forced to end up coming to the table in a way that they weren't happy about, and reimbursing Memorial Sloan Kettering much more than they wanted to. And then, of course, those cost increases got passed along to their members. And we see that, and it's not just Blue Cross Blue Shield and Memorial Sloan Kettering. We see it with UHC and Duke, Blue Cross Blue Shield and University of California Health, Aetna and Trinity Health. In New Jersey, we had one with Cigna and Atlantic Health System not that long ago. So you're going to see more and more of this, shorter time frames for the contracts between hospitals and the insurance networks. And that too will continue to drive costs upward. And then the one that doesn't get talked about a whole lot is the monopolies, lobbyists, and trials. Prior to the passage of the Affordable Care Act under the President Obama's administration, in our country, about 80% of all physicians were sole proprietors. They were in their own practice, or they were in a small practice that they were part owners of. 20% of all physicians in this country were employees of hospital systems, in some cases, corporations, some private equity type firms that own practices, that type of thing. Following the passage of the Affordable Care Act, those numbers turned around completely. At this point in time, more than 80% of all physicians in our country are employees, and most of that are of healthcare systems. We've also seen a huge purchase. We've seen a lot of mergers and acquisitions in the hospital space. So where in a lot of places we used to have a lot of independent hospitals around, there all those hospitals are being gobbled up by bigger health systems. Here in New Jersey, we have basically 3 healthcare systems that own about 90% of all the hospitals, and a 4th system that's based out of Philadelphia owns a number of hospitals down in South Jersey. So as we see less and less competition, we see higher and higher costs, and that's what's happening both with physicians as well as hospitals. So we're seeing a lot of that. Lobbyists don't want to go down a dark hole. when it comes to politics here, but I think a lot of our country's ills would be resolved if we could just eliminate lobbying altogether. But that's not going to happen in my lifetime, unfortunately. The healthcare industry, pharmaceuticals industry in particular, but the healthcare industry in general, far and away spends more money on lobbying than any other industry in our country. Think about that. Think about that as you see as you watch a sporting event on the weekends, and you can't look at a sporting event without drugs being advertised on television right now. All sorts of fun song and dance and this and that and the other thing. Well, every single one of those drugs that you're seeing advertised there are drugs that do not have a generic equivalent. They're all costing thousands and in some cases tens of thousands of dollars a month. And of course, they're being advertised because the manufacturers of those drugs want you, the member, to go to your doctor and say, hey, I know I've been taking this medication for my diabetes or my irritable bowel syndrome or whatever it is. And it's been doing a pretty good job for the last 7 years. And that's fantastic. But I see this other great new medication. Should we maybe try that? And doctors are happy to go ahead and turn around and try that new prescription. But that new prescription doesn't have a generic equivalent. So you can quickly see a member's medications go from costing a health plan $100 a month to costing a health plan $5,000 a month. And that happens very quickly. And of course, um, it's about a it's about 12 years to get a new drug through all of the FDA testing on a regular basis. And then once a new drug is established and put out there in the marketplace, it's 20 years before a generic equivalent is allowed. So and as more and what we're seeing a lot of times is these drug manufacturers, as they're getting to the end of their exclusivity period, they make a little tweak in the drug, and so now it's improved. They add a little ingredient or one or time release, whatever it may be, and then that extends that period. And yes, there's a generic equivalent of the old one, but people aren't asking for the old one anymore. So all of these are coming together and for putting upward pressure on the costs that we're paying for healthcare. And then finally, the last one is the trials. Something that never seems to get addressed whenever anybody talks about any kind of healthcare reform in our country is tort reform. Uh, Medical malpractice insurance costs hospitals and costs physicians hundreds of thousands of dollars a year, and all of that gets reflected in our costs. And so we can't really truly have full healthcare reform until we eliminate some of the pressures of the lobbying and until we create better ways to get more affordable drugs into the population and until we come up with some type of tort reform as well. So what does all this do? Well, it puts pressure on you, the employer, as well as your employees on the cost of purchasing and maintaining health insurance. And as you can see by these charts, and it doesn't matter where you are in the country, wages are not keeping up. The wage increases are not keeping up with premium increases. And so you as the employer are seeing your profit shrunk as your costs are going up every year, but also at the same time, your employees are seeing more and more of their paycheck as you pass along some of these costs to the employees, seeing more and more of their paycheck going to pay for healthcare costs, and their wages are not keeping up with those increases. And so this is making things very challenging. And for the small employer that doesn't know whether or not they wish to offer health insurance, it gets more and more difficult to find the talent that you need to maintain and grow your business. And all of these pressures are not making it easier on you. So finally, you make the decision that you want to get health insurance, or that you need to offer health insurance to your population. And then there's all sorts of mountains that you have to climb just to make it all work. We have four major carriers out there: Blue Cross Blue Shield, Cigna, and United Healthcare. Which is the best for you? Or is one of the regional carriers best for you? And that could be the case. And then once that gets established, How is that going to work with your payroll integration? What is the underwriting process for how are your rates determined? And there's underwriting in all health insurance. Now, yes, there are no pre-existing condition exclusions in the small group fully insured market, but there's an underwriting process that determines the rating. In the small group fully insured marketplace, the underwriting is done on the geographic area. Carriers and the market are looking at what is happening in a particular zip code, and they're basing their pricing on that, the health of the population in that zip code, the cost of medical reimbursements in that zip code. With larger groups, underwriting is done on a more individual basis, looking at the health and the age of a particular population to determine rates. So a lot of factors can come into play. Of course, there's the broker. If you're going to offer health insurance, generally in this country, you have to work with a broker to make it happen. So is the broker providing you with the resources and the service that you need? Brokers get paid in one of two ways. The traditional method of paying a broker is they get a percentage of premium, and that's the commission. To me, that's kind of an upside down market. You see a 12 or 14% rate increase on your health insurance this year as a small business owner. That means your broker just got a 12 to 14% pay raise because his commission or his or her commissions are mirroring your increases. There has been a trend in the marketplace to move away from a percentage of premium for commission and move to a flat dollar amount, a per employee per month charge, if you will, or a consulting fee. I'm not saying one is better than the other. I'm a fan of the per employee per month fee. I think it provides more of an incentive for your broker to try to keep your costs down. But I'm not saying one is better than the other. But you should know, how is your broker being paid, and what services is your broker providing you to earn those dollars? Yes, getting you the best rates, but in the small, fully insured marketplace right now, brokers have no control over the rates. The rates are set. And there's nothing that one broker can get you that any other broker can't get you in the small group fully insured marketplace. So what services are they? Are they providing compliance? Are they helping you with a benefit admin system? Are they helping you determine what are the best rates? What are the best plan options for your employees? And how is that going to work? And are they providing you the service? So these are all things that you, the business owner, have to keep in mind as you're shopping for health insurance in the marketplace. So then finally, what are the ways to go? So there are a lot of choices for the small to mid-sized business owner. Choice A is to do nothing at all, but we're finding more and more employers are saying, well, I can't get people to come work for me if I offer nothing, so I have to do something. But I don't really want to go all in, and I can't afford to do too much. What are my options? Well, putting a toe in the water is setting up an individual consumer health reimbursement account. That is kind of the first step, if you will, if you don't want to fully commit to going into getting a comprehensive health plan for your people. One thing that you can do is through a ICHRA or a qualified small employer health reimbursement account. You can set up a system where you're contributing X number of dollars each month to an account for your employees. That contribution that you're making is a tax deduction to the business. It is a pre-tax event to your employee, and your employee gets those dollars, and they can use those dollars to go out and purchase a health plan on their own through the exchange if they want, or maybe not get a health plan, but use those dollars to go reimburse the doctor for the office visit that they just had, or to go to the urgent care center that they just went to. So that's kind of putting a toe in the water. There's tax advantages to doing that. And it gets you doing something for your employees, trying to make them a little stickier. But it's just, the first step. A more comprehensive step would be to go out and procure a group health plan. We have a couple different ways to go. For the small business owner, if you're out there and in certain states, your only option may be this a fully insured small group plan that's community rated. The health and the setup of your population has no impact on your rates. The rates are determined by the plan design that you choose, as well as the rates that are filed and set in your state. And they may be age banded, and they are in most states, or they may be a composite where all singles pay the same rate. Depending on what state you're in. New York uses a composite system. A lot of other states in the small group market only use an age banded system. And so it may be a good option for you. If you're a company that has nothing but 27-year-old male employees that are all in reasonably good health, then that small group community plan that's age banded may be great for you. If you're, however, you're in a state where the state uses aggregate rates, well, then it probably isn't a good option for you because your 27-year-olds are paying the same as the company next door that has a bunch of 54-year-olds. And 54-year-olds are obviously going to cost the healthcare system a lot more than 27-year-olds are. So there's some subsidization going on there. Moving further away from the fully insured market, depending on how big you are, you may be able to go out and get a level funded program on your own. Level funding is the first step towards self-insurance, where the health of your group is helping determine what the rates are that you're going to pay. And at the end of the year, if claims have been less than what the underwriter expected, there may be a return of premium to you. If they're greater than expected, you're going to see a rate increase and no return of premium. For larger companies, and depending on what state you're in, California and New York, you got to be over 100 lives. You could possibly self-insure. That is taking a little bit more risk into the equation, but it is a way to possibly put in risk management strategies and help keep costs down. And then finally, for the mostly small and mid-sized business owner, if you happen to be a member of an excellent association like the NLA that's very proactive in trying to offer their members as many benefits as possible, there may be an association option that is available to you. And in this case, there is. And that option is going to work and work well for probably about 85% of the membership. But there will be members that it won't work for a variety of reasons. There will be members that will want to get into the association plan, but because of the health of their population or possibly a dependent of one of their employees, they're not allowed to come into the program. Or they would be allowed to come into the program, but at a very high rate, and it makes more sense for them to be out there in the community rated marketplace. So a lot of different options. Bona Vita is here. Yes, we are the broker on the NLA association option, but it's not the only option that we work on. We work on a lot of different things. So if the association plan is not the right fit for you and your business, we may have an alternative to help you with. Another option that you can look at if you're of a certain size is a professional employer organization. This is a setup where kind of your population is being coupled with a lot of other populations, generally of similar size, maybe similar industry. And you are going into a joint employment relationship with an ADP Total source or a Paychex, or there's JustWorks. There's 400 plus PEOs out there in the world. And I'm sure you're getting called by some of their salespeople telling you that it's the best thing since sliced bread. And it may be for you. But what it means is setting up a separate Social Security ID, not Social Security, tax ID number. It means that company taking over your payroll, in many cases, your workers' compensation and liability coverages, as well as your benefits. And sometimes, while the benefit cost may be lower, the additional admin costs for the payroll, et cetera, may end up costing the organization more money. And a lot of times with these PEOs, they try not to be very transparent with their rates. So if I'm not against PEOs, they're a great fit for a lot of organizations, but make sure that you're working with a broker or an organization that understands how they work and can help you decipher all the differences and help you determine what's the best option for you and your organization. So those are kind of all the options that are available to you as the small and mid-sized business owner if you want to provide some level of benefits to your employees. Now we're going to do a little bit deeper of a dive into the NLA Association Health Plan. We have multiple designs in this plan. It's an exclusive benefit. You have to be a member of the NLA to get into this program. We have 8 different plan design options. Right now, there's 2 different networks, working on getting a third here in the upcoming year. Pretty easy process to quote. There's one of 2 ways to go. If you have health insurance in place right now, a group health plan in place right now, and you have at least 10 employees that are participating in the plan, well, then in order to get a quote, all we need is a special census to be completed that includes the employees as well as their dependents, current plan information, and in about 2 to 3 days, we can have a quote for you, determine whether or not there's a better option through the NLA plan for you. If you don't have a plan in place today, or you do have one and there's fewer than 10 employees participating, then there's an extra step in the process. Each of the employees need to go click on a HIPAA certified secure link and fill out what's called a personal health questionnaire. I best equate the personal health questionnaire to if you've gone to the doctor recently and you step into the waiting room and the receptionist, you check in and the receptionist hands you a clipboard with 3 or 4 pages stapled together. And it says, check the box of every health condition you've dealt with in the last 5 years and list for me all the prescription medications that you're taking. It's very similar to that, except it's done online, very securely, HIPAA certified. And nobody at the NLA, the employer, nobody is going to see the information that the employees put on this form except for the underwriters of the program. That is going to be used by the underwriters to determine first if they're going to accept your group into the program, and then if so, what rate tier they're going to set you at, because they first look to see whether or not you're a healthy enough risk to come into the program. And then assuming that you are, and like I said, about 85 to 87% of the groups that apply are accepted into the program, then where on the level of risk are you? Again, if you're, a bunch of 27-year-old single men, you're going to be down there rate tier 1, which is the lowest rates possible. If, on the other hand, you have a bunch of people that are my age starting to deal with the health conditions that we deal with as we get up there in age, you might be in a rate tier 4 or 5, where you're dealing with blood pressure and diabetes and hip replacements and things like that. But regardless, if you get in, there's generally going to be some savings, and we conservatively say 10 to 15%. You'll see in just a slide or two that it can be greater than that in some parts of the country. In addition to that, it comes with Bona Vita, who's there to provide benefit support through enrollments, answer questions for both the administrator as well as the members of your team that are participating in the program. How does it work? Well, Triad is the program manager. They have put all of this together. They've gone out, they've hired third-party administrators. Right now, we have 2 of them. The Acuity Group has been handling things for the last couple of years, and they've now come to an agreement with Securus Benefits, which is another third-party administrator. We're starting to see more and more cases being put with Securus Benefits, as they have greater technology capabilities. Cigna is our main network. We also have the PHCS network and a reference-based pricing option. Works in some parts of the country, doesn't work in other parts of the country. So depending on where you are, will help determine what is the best route for you to go. And then we have 2 different pharmacy benefit managers. Both of them are transparent fiduciary pharmacy benefit managers. These are the organizations that procure and source your drugs for you. Both of them are transparent, and their fees are all disclosed, and they can source drugs in more than one location. In fact, with some of our clients, they go overseas to get some of the drugs because they're less expensive. Bona Vita is the program broker. We're here to help get you the quotes, and if indeed this program makes the most sense for you and your organization, to help get everybody enrolled, get it established, and then provide ongoing service throughout the course of the year with this program, leading up to every renewal. And then finally, we have a typo here. We have the sponsoring association. Apologies, it's not the Independent Electrical Contractors Association, though they are a client of ours. This is the NLA program. Getting quoted, it's pretty simple. I just mentioned it. We need some data. Again, depending on the size, census, a listing of your employees, a very special census if you have the 10 or more employees. We want to see current plan information, et cetera, et cetera. Once we get that in at Bona Vita, we package it all together. We send it to the underwriters, and they're coming back. Right now, they're coming back in about 2 to 3 days with quotes. As we get closer toward the end of the year, that will extend to 3 to 5 days. The busiest time of year in the health insurance industry is the fourth quarter. And as we get ready to go into that, you'll see that it'll take a little bit longer to get the quotes, but we're still getting them turned around pretty quickly. Once we get the quotes back, we put them in a proposal for you. If we have your current plan information, if there's a current plan in place and you've provided us with everything, we'll provide a side-by-side don't always match up exactly with what you're doing, but we'll provide an analysis side-by-side with our closest match. And at that point in time, you, the organization, will determine whether this is the route that you want to move forward with or not. As I mentioned, we're saying there's generally 10 to 15% savings, greater in some parts of the country than others. In the New York City area, we're seeing savings as high as 35%. New York is the fifth most expensive state in the country for health insurance. Up in Vermont, it's the most expensive state in the country for health insurance, seeing either greater savings. West Virginia, Alaska, also huge savings as healthcare costs are very high there. In places like Iowa and Nebraska, the savings is not as great. So that your savings is going to vary depending on A, the makeup of your organization, and then B, where in the country that you are, because the rates are the rates for the entire country. So that will all have an impact on what you actually pay. I mentioned we have 8 different plan design options, going from very rich, very little out-of-pocket costs, to more value type plans where the participating members are going to see more out-of-pocket costs. These plan options are available with all of our networks. So obviously the 1,000 Classic with the least out-of-pocket is going to be more expensive than 3,500 Classic. All of these have both in and out of network benefits, and they work in all 50 states. And then we go to more value type plans where there's greater out-of-pocket costs for the participating member. And then we have 2 HSA options. If you are currently offering, or you want to offer an HSA, a high deductible type option, where a member can also set up an HSA and put dollars away on a pre-tax to offset any uninsured medical expenses or unreimbursed medical expenses, they can do that as well. We have a number of features in this program that are pretty unique that you won't find in more traditional markets. And one of those is participations. In the traditional market, whether it's a small or mid-sized group marketplace, the carriers are going to require a certain percentage of your population to participate in the program, or they won't go live. With the NLA Health Benefit Program, we do not have participation requirements. You can have a company of 7 employees and only one of the employees wants and needs the coverage. We can go live. So we can go down to a group of 1, and there are no participation requirements. So it makes it easier for you as the business owner to provide a program and not worry about, well, you have a lot of people that aren't going to participate for whatever reason that may be. So that is not an issue with our program. Sorry that you have to look at pictures of us, but this is the Bona Vita benefits team that works on the program. Phil Shetson is the founder and owner of Bona Vita. He is involved with the program. This is all I do for Bona Vita is run and build this program. And then Millie and Amy are working with the administrators at each company, as well as the employees that are needing help for a variety of reasons. Once a group joins the program, the member as well as the administrator have access to an admin portal as well as an app that goes right on a smartphone where a member can use it to check and see where they are as far as meeting their deductibles or their maximum out of pockets. Do search for a provider. Look to see where is the nearest lab. I've been given a prescription to get blood work. Where's the nearest lab that's in network? All that is available on their smartphone. Finding providers, they're both available through a desktop version as well as an app for the phone. So this is something that every member gets. Member experience, it works just like it does with any traditional type of health insurance. Your employee gets sick, they go to see a doctor. The doctor sends an invoice. In this case, they're not sending it to Cigna, they're sending it to the Acuity Group or Securious Benefits, whoever the third party administrator is, Securious or Acuity. They're looking at, all right, what is the negotiated reimbursement for this bill that Cigna has negotiated? They get to use that same negotiated rates. They're paying the invoice. The member's happy, the provider's happy, everybody's happy, and your employees are healthy again and get back to work. Pretty simple to get quoted, meet the team, etc. We have websites available. Right on the NLA website is access to the site that we have established and maintain where you can request a consultation, complete this. It comes an email, gets delivered right to me saying, hey, you want to learn more about this and how it may work for your organization. I reach out to you in a couple days and we discuss it. And if indeed you want to move forward getting a quote, we start talking about getting us the information that we need to do that. Also on this site are frequent, links to frequently asked questions, the plan designs that we just went through, download the census format that we need for groups that have 10 plus employees on, and then provider searches. If you want to find out whether your doctor is in the Cigna network, or if you're in a rural area and you're considering the PHCS network, because it's about 10 to 12% less expensive than the Cigna program, you can search to see whether your doctors are participating there as well. And that is the team. Well, Julia is no longer with us, and et cetera, et cetera.